Right then, rehabbers, welcome back to another video, and this week's video learning will be on the posterior shoulder. So it's going to consist of 3 videos that will be played at different periods over the next week. One of the videos will be obviously on the subjective, objective/special tests for posterior shoulder pain. Another video will be on how to rehab the shoulder. So starting at low level and building all the way up to plyometrics or rate of force development. And the very last video will be how to assess a shoulder MRI and how to look for rotator cuff pathology, to look for labral pathology and all of those kind of things. And hopefully you find it enjoyable. If you just bring your arms by your side and come out as far as you can and come back, and don't let me push in. So we're looking at isometrics. Don't let me push out. And then relax. And then I want to see again how much movement you've got coming back up. Down a little bit and then out. You can also obviously test the strength in that position as well. Come back, take your arms up to here. Bring your elbows in a little. Don't let me push your hands together. And relax. And again. Good. And relax. And then obviously we also look at abduction through range. And back. And obviously flexion through range. And back. And hand behind your back. And relax down. Right, so we've got our lovely patient here, Debs, and we're going to be looking at lateral rotation. So I just want you to put your arm by your side and then just coming out and then back. Now, if we imagine that she moves about halfway and then it's stuck, we can't go any further. So we don't know if it's purely a joint problem, a muscle problem, or a bit of both. So one of the things that you can do is give some passive elevation, so you're just offloading the shoulder a little bit, and then some support to the arm, and then you can get her to do the movement again. So if you just come out and move the shoulder, and you can see if it's any better when you're you're offloading it. If we find that the movement gets full when you're offloading, then obviously it's more of a muscle thing. I also generally, if they can't get completely full with support, I also, for me, do a passive assessment as well, just to make sure. So the next part of the video is about symptom modification. So if we get our lovely Debs here to lift her arm up in the air. Okay, come back down. So imagine we're coming up and she gets back there and it hurts. Okay, so come back down. We then can do some things to see whether it will help. So first thing we can do is shorten the lever. So if you bend your elbow like that and then just reach up for me as far as you can and see if that's better, worse, no different. The other thing we can do is get her to do some upward rotation. So activating the upper fibers are trapped. So I want you to shrug your shoulder and lift up for me. And does that make it better, worse, no different? The other thing we can do is if you make a fist and clench that fist and then take your arm up in the air and come back down. And is that better, worse, no different? As Debs is so small, we've had to go outside in the garden because I haven't got a good enough lens. So this time what we're going to do is we're looking at the effects of the kinetic chain. So what we're going to do in a second is, if it's my right shoulder, we're going to get it to step forward and take the arm up at the same time. So looking at my beautiful assistant, okay, so stepping forward and up and again and back. You can also do the scapular assistance test. So what we'll do now is if you turn around slightly and then when I say go, just come up like that for me. And you're going to have your hand on the inferior border. Okay, you ready? And I usually have one hand just under the chin without strangling her. Okay, and then up and add elevation and upward rotation if you need to. So do that again and down, and to see whether that helps as well. The other thing we can do with symptom modification is making it easier, so doing it in supine. So can you take both of your hands over your head and then back, and we can see if that's easier or harder or just the same as in standing. And then finally, what we do now is get band, and we're going to create a little bit of abduction force as we're lifting through range. So if you hand through there, and then with your elbows straight, push a little bit of pressure into abduction and keep that pressure on as you're lifting your arms up over your head and back down. So the first test is the Dynamic Posterior Instability test. So we've got our willing victim here, and we're taking our arm up to roughly about 140 degrees, and you're going to try and push further as she's pushing into you. And a positive is pain in the posterior shoulder plus or minus apprehension. So we take the arm up to about 140. We are trying to do a flexion, so we're trying to do that, and she resists. And a positive is pain and or apprehension posterior shoulder. The next test is the Whipple Test. Don't know who names these. Put your hand of the patient on her opposite shoulder, and what we do now is when I say go, you're just going to come up like that and push up for me and relax. So again, she'll be pushing up, so push up. And a positive test is pain and or apprehension in the posterior shoulder. If this is sore, what we can do then is we put a anterior directed force on the head of the humerus and get her to repeat. And a positive is when the anterior directed force is less painful than doing it without. This next test is Briens Test. So we take the arm up into 90 degrees with your thumb up, slight adduction by about 10 degrees, internally rotate, and then don't let me push you down. And if this reproduces her symptoms, we turn the hand into supination and don't let me push down. And a positive is pain and or apprehension in the first test and eased in the second test. So while we're looking at possible labral causes of the posterior shoulder pain, we can do the bicep loads 1 and 2 test. So 1 is you keep the patient in 90 degrees of abduction and 90 degrees external rotation, 90 degrees flexion, so 90, 90, 90. And then we get her to do this, and a positive is if her symptoms get worse. So push down for me. Okay, so she's pushing this way, I'm resisting, and it's a worsening of symptoms, which can be pain and or apprehension. Just make sure that the shoulder does not change position for abduction or external rotation or it's just the flexion. Bicep load 2 test is then in a slightly higher position, and she's going to do that. So what I'm going to do is just to push down for me. So again, she's creating a force towards her head. I'm pushing away, and a positive is a reproduction of her pain and or apprehension. And the next set of testing looking at posterior shoulder pain is for the quadrilateral space syndrome, which is the quadrilateral space is formed by the teres major inferiorly, which, as you know, there's the border of the scap. It's coming like this. Superiorly by teres minor. And we've got medial by long head of triceps and lateral by the humerus. So we are looking around here. Now around this area, you also obviously have the axillary nerve, and that will supply motor functions for the deltoid muscles and teres minor. and it will also provide sensory innervation to the lateral shoulder. So some of the ways you can sometimes test this, obviously the main one is looking at muscle wastage of the deltoid and teres minor. But the other things you can do Tinels to see if that reproduces anything. You can do pinprick, so without actually stabbing Debs, we basically can do sharp and blunt to see how that is, including on the lateral side or the lateral deltoid, medial deltoid, around there, because that's where the sensory innervation is. And you can also do hot and cold. So for example, you can have 2 coins, one in your pocket that's been staying there and one room temperature. And you can put them on different ones to see if the temperature change is picked up by the patient. Do they feel different to both sides?